Hope my screen is visible and I'm audible too. So, good evening to everyone. I'm Dr. Omkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in this next session of No Thrombosis. So, we are conducting this interesting program for now last 2 years, and we feel it's this program is dedicated to all interventional cardiologists, where we discuss live in box cases by leading interventional cardiologists, and along with that, the most interesting intellectual feast is the expert commentary by our coast director and our course moderator. So it gives me an immense pleasure to welcome our course director, sir, Dr. M.S. Hiremat, sir. Sir, we all know sir is a director at Cath Lab at Ruby Hall Clinic, Pune, India. Sir has been a president of CSI 2017 and convener for National Interventional Council of India of CSI from 2004 to 2006. Sir had proctored many interventional cardiologists and has given live courses across the globe. Though coronary interventionalist at heart, he is equally adept at peripheral arteries interventions like leg, carotid, and aorta. Sir has been participated in many groundbreaking study. So thank you very much, sir, being a part of this program. At the same time, I taken a privilege to welcome our course moderator, Dr. A. Srinivas Kumar, sir. Sir is currently working as a senior consultant cardiologist and director at cardiology and clinical research at Apollo Hospital, Hyderabad. Sir has been a chairman of a FACT Professional Services and founder editor of National Medical Journal of Postgraduate Medical Clinics of Usmania. He is a founding course director of Advanced Cardiovascular Solutions of India, ACVS India, and TCT India and South Asia Conference. Sir had an interest in TAVI, ASD, VSD, OCT, IVUS, and IFA. Sir has been a president of a Cardiology Society of India for AP chapter, and sir been a part of many clinical trials as a principal investigator and co-investigator. Thank you, sir, being a part of this program. I taken a privilege and opportunity to welcome our course moderator, Dr. D. Prabhakar, sir. Sir is a consultant interventional cardiologist at and associated with Apollo First Hospitals and Ashwin Clinic at Chennai. Sir has been a treasurer for CSI 2022 Chennai conference and assistant professor of cardiology at Madras Medical College from 1998 to 2002. He has been participated in many national and international conferences and faculty and published many articles in reputed national and international journal. And I take a privilege to be a co-author with sir in our recently published articles on iron and heart failure, as well as Arnie remodeling by Arnie and heart failure. Now I take a privilege and honor to welcome our case presenter for tonight, Dr. Samir Kuba, sir. He is Associate Director and Clinical and Interventional Cardiology at Max Super Specialty Hospital, Ghaziabad in UP. Sir will be presenting sudden death after successful angioplasty. What's the cause? It seems very interesting discussion is going to happen tonight. At the same time, I welcome our second speaker for the night, Dr. Amit Thopte, sir. He's an interventional cardiologist at Anand Rushiji Hospital and Research Center, Ahmednagar, and he will be presenting unusual case of stent thrombosis. This will be our flow of the program, and I will stop here, and I would like to hand over this session to our faculty for tonight. Okay, over to you, sir. Hiremat, sir, and maybe...
Okay. Thank you, Dr. Omkar. All of us are gathered again. And as I understand from Dr. Omkar, last many sessions, I think we have over 50 sessions together.
Yes.
And all have been very, very strongly appreciated. Our faculty keeps changing, and currently Dr. Prabhakar and Dr. Srinivas Kumar are with us. So I hope they all make a big sort of opportunity and expertise yourself by asking questions on a presented case. Over to you, Omkar. We can get to the case.
Yeah, we can start, sir. Dr. Samir is here. Dr. Samir.
Thank you very much. Are my slides visible?
Yes, yes.
Okay, thank you. So thank you, esteemed chairpersons, moderators, and all my senior colleagues over here. So this is a case which I did many years back, and just within 20 minutes of a successful multivessel angioplasty, this patient actually died. So this was an elderly man who presented with weakness, fatigue, and chest discomfort of 1 day duration. The ECG showed an infero-posterior MI. He was fairly stable as far as his hemodynamics were concerned. And that was the ECG. He was actually admitted under the physician because his symptoms are not typical of a myocardial infarction. So these are some of the baseline parameters. The troponin was positive. The echo was reported as an LV function of about 30-35%, mild MR, and regional wall motion abnormality in the posterior and the lateral walls. So initially, we advocated an angiogram. The family was reluctant, but ultimately, after 2 days, they agreed for an angiogram. So this was the angiogram which showed a critical stenosis in the LAD and also a long segment disease in the circumflex. If you look at the right panel on the iliocranial view, there's either a thrombus or a spontaneous sort of a dissection in the left circumflex system, and the LAD proximal was quite tight. So we decided to perform an angioplasty, which was successfully performed. A minimum amount of contrast was used, a lot of tortuosity in the femorals, so a long sheath was used, and the result was good, and it was a quick procedure, and we shifted the patient to the CCU. So our CCU and the cath lab are on the same floor, and we were just in the cath lab discussing with the family and seeing the angiogram and discussing with our colleagues and preparing for the next case. And we received a call that patient has suddenly collapsed within 20 minutes after the procedure. The ECG showed a heart block. He was immediately intubated and inotropes were instituted. So the first thing which comes to the mind of an interventionist is always a stent thrombosis or maybe a coronary perforation. And in the hush of things, we decided to shift him with cath lab for the check angiogram. But anyhow, there was something which was clear in my mind. The results were good and procedure was fast. So something actually was telling me that the way he has suddenly collapsed, it's probably something else. So we did a bedside echo, which revealed a large pericardial effusion, causing a tamponade. And as a desperate measure, we just started to aspirate and give him water transfusion. But it was so sudden that the patient actually did not make it. And after a trial for about half an hour to 1 hour, we actually lost him. Now, these were the static echo images. As you can see, there's a large effusion over there. Now the retrospectively, we thought to analyze that why this has actually happened. And we went back and reviewed the coronary angiogram, which did not reveal any leak or perforation, spontaneity flow after the procedure. Next day, I went to the echo lab and discussed the echo with my non-invasive colleague. We looked at the images, and these were the images in the echo lab. There was some pericardial effusion, if you can see anteriorly in the left panel in the plaques view. And if you look here, there's something in retrospect which bothers me. And there's some mitral regurgitation. But the point is, at this point, I thought there was something which we had missed. And this point probably had a contained sort of a cardiac rupture to begin with. He was an elderly man, delayed presentation. Some effusion was already existent over there. So probably the patient had a LV free wall rupture. The question is, why did it happen immediately after angioplasty? Was it a manifestation of reperfusion injury, or there was a dislodgement of a clot sealing the contained rupture? Heparin was used, and sometimes when you do a procedure, the LV function also starts to improve and following the reperfusion, and it can dislodge the clot sealing the contained rupture. So this is in retrospect, we realized that most of the times what happens is we don't do the echo ourselves and our non-invasive colleague does the echo. And sometimes in a busy echo lab, these things can be missed, and especially in elderly patients, delayed presentations, one must actually look at each and every aspect, and the importance of each and every step in the management of these patients is very, very important. Now, just to briefly review that LV free wall rupture is a dreaded complication of acute MI, the incidence being highest within the first 24 hours. And then it decreases progressively, and beyond the 5th day post-MI, this is uncommon. The onset is usually acute in the form of tamponade, although it can be subacute. In our patient, it was very, very fast and happened just after angioplasty. The risk factors usually are female sex, advanced age, complete obstruction of the infarct, and first transmural anterior lateral wall infarction. The clinical presentation could be acute or subacute and depends upon the rate and amount of accumulated pericardial bleeding. Most cases present with sudden hemodynamic collapse followed by death. And in some cases, the blood clot will seal the pericardial leaks and form a left ventricular pseudoaneurysm. We have few cases of pseudoaneurysm, all of us in our practice, although it has now reduced with better reperfusion and early diagnosis of the patients. The hallmark of the subacute variant of the free wall rupture is slow, repetitive, intermittent bleeding, which occurs in 1/3 of cases. But dissimilar to the classic LV free wall rupture, the subacute variant may present slightly slowly, and patients may endure until emergency surgery is arranged. Signs and symptoms are persistent chest pain, intractable vomiting, restlessness. ECG may show persistent ST segment elevation and positive T wave deflection that persists for about 72 hours after the onset of chest pain. The classical signs of tamponade may actually be absent and may not exist in most of the cases. And this is something which we must know very, very clearly. The diagnosis requires actually a very high index of suspicion and close monitoring, and we must preempt these kind of things and maybe look at these kind of things prospectively and actively before taking these patients to the lab. Echo is definitely the gold standard, but at times it can miss the diagnosis, especially if you're not looking for the diagnosis. As you know, the eyes don't see what the mind doesn't know. And the MDCT, which is computerized tomography, is actually a suitable alternative if the diagnosis is doubtful, to exclude other etiologies of hemopericardium. And after this case, I have been more and more, I would say, cautious in taking these delayed presentations. Although I work at a center where we do primary angioplasty and patients usually come within half an hour to 1 hour, but sometimes in a month, 2-3 cases come who are delayed, and they have those kind of borderline blood pressure, some tachycardia. So we look at the echo ourselves, and 2 or 3 patients we have actually identified a pericardial effusion in these delayed cases, got a CT done, and in one case we had evidence of a free wall rupture, and we did an angio and immediately shifted him for surgery, and he is doing well. So sometimes you can also do a cardiac MR, but this is usually for stable patients with subacute free wall rupture or pseudoaneurysm, and for more defined tissue characterization. But most of the times it is the echo and the clinical judgment which is important, and it can be corroborated with the CT scan, especially if the patient is not that stable, and an MRI if the patient is relatively stable. Management, usually it's an acute emergency, needs a surgical closure. Pericardiocentesis is usually a desperate procedure. Usually it doesn't help much, but at times you don't have any other option. You can do a pericardiocentesis just to stabilize the patient before he is shifted to the OT. And surgical repair is actually the treatment of choice. Thank you very much.
I think reverse the heparin. That is also equally important. So depending on how much is the gap between the last heparin and the pericardial effusion or rupture of the myocardium, you need to consider giving him a heparin reversal antidote.
I think, sir, that's a valid point, but in situations like this, when it's so catastrophic and it's a mechanical complication, recently stented with 2 long stents, I mean, whether it is actually going to help or no, making a diagnosis actually is, had it been a slow leak or the perforation, something of that sort, possibly reversal of heparin, definitely. But in this patient, actually, we were so tied up and we tried to do everything. And I don't know whether the heparin reversal would have actually helped him. He didn't give us time, actually.
Also, the spot on the echo where you are saying a possible rupture, had the echographer shown any flow out from LV to outside?
So the echocardiographer had actually missed it completely. And it's usually like ACS, LV, RWMA, EF 3035. We took him to the lab. And when this happened, and when we found that the way the rupture has happened and the effusion has collected so suddenly and so catastrophic way, so retrospect, we went back and looked at the images again and again, and then he realized, yes, he had missed it. And that area actually had a discontinuity. Obviously, the flow across that area we could not identify very clearly. It's at times not possible, but that went, and that discontinuity with the presence of amount of pericardial effusion which was there actually made us think that this is something which we should have looked at prospectively, although these things are at times missed. And I think all of us have these kind of situations. And many times the patient suddenly die even an echo is not done. So in this patient, we had an echo and we could demonstrate that effusion and that hyper-echogenic area in the pericardial cavity.
I think your case also highlights doing an echo before and after in the cath lab. So I would probably feel
absolutely, sir.
Yes, I mean, if you were doing the echo, you would have probably got worried about the site which you are showing now as a possible site of rupture. And I'm sure if it had happened in 20 minutes, there would be some leak evident if a post-procedure echo was done. Also, we have a lot of these anticoagulants. So many times, in addition to heparin, we use GP blockers, and especially in a setting of acute MI, that actually worsens the bleeding as a catastrophe. And I would feel it's a combination of many. And in our hospital, I mean, we are much smaller than your hospital, but in our hospital, we have an echo done as the nurse is painting and getting the patient ready. And the operator or the associate, he will do one more echo as the nurse is getting ready to ship the patient out. So I think I would probably feel it's a very good habit that we have cultivated, and it's a routine for every consultant who is doing a procedure in our lab. I'm not trying to say it's a great help, and we have picked up lots of cases who would have landed into a tamponade and ultimately death. But I'm sure you, as a interventionist, have a bigger suspicion compared to somebody who is doing isolated echo study.
Absolutely. But in this case, sir, I think it was more of a retrospective analysis, and maybe prospectively, even I would have missed it, because the way it happened, and obviously the echo was done 2 days prior on the day of presentation, and the family was not keen and willing for a procedure, and he was on medical therapy, including heparin. And then they agreed one fine day, patient was stable hemodynamically, so we didn't think of repeating the echo, and we just relied on that. Having said that, this kind of a rent or this kind of a trace pericardial effusion, I think it has made me more wise since that event, which happened around 7-8 years back, and especially in patients who are at risk of these kind of things, especially the delayed presentations, elderly people. I am more cautious in looking the echo myself, and even very worried about traces of pericardial effusion and making unconventional images to actually look at those areas, because conventionally these rupture sites are not at the actual, routine areas. And we have saved a couple of lives. We have also done MDCT in 3 patients, and in one we have identified a rupture and contained rupture, obviously, and then did an angiogram without heparin and explained to the family, despite an angioplasty lesion, that surgery is going to be better. So we have become wiser. Doing an echo, no doubt, definitely in the cath lab before the procedure starts is a very, very good idea. But at times, because of constraints and other things and busy cath lab, it may not be possible. But I think the importance of echo must never be under-recognized.
Ask our colleagues, Dr. Srinivas and Dr. Prabhakar.
Thank you, Dr. Samir, for showing an interesting case. Basically, as highlighted already, echo is mandatory. Even if it is primary PCI, even if it's taking 5 minutes more, it is mandatory, especially in acute MI scenarios, as you know. The contained rupture, it definitely shows there is a thinness of myocardium there. Sometimes you may not document the flows. It could be small clot which is occluded, and once you give heparin, the clots get dislodged, and then more tamponade starts happening. That is one which has happened in this case. And the second thing is, doing an echo gives a lot of confidence for us also. If LV function is normal, then you will be more aggressive, and probably you have a lot of confidence doing the procedure, even if it is taking a little longer time, whether it is giving fluids, and a lot of other benefits also are there apart from avoiding such complications. I think just to have a feel of contractility of LV before you're doing the procedure, that adds a lot of confidence to the operators, I feel. I have always, as sir said, it is better to check it once before and if possible after. And regarding your discussion of what could have happened, other causes are okay, stent thrombosis, perforation, other things. But immediately the so rapid presentation always it points to pericardial effusion and tamponade. Whether it is because of wire perforation or stent stretching, rupturing the artery, or a pre-existing leak like this. So tamponade is on the top on the priority because of timing, which is so fast, which has happened. And by and large, if you see the neck of these patients, it will engorged and the blood pressures will be low. Invariably, if you immediately, sometimes you take more time, 5-10 minutes also makes a lot of difference. If you do immediate tapping, sometimes we could save these patients. So whereas other stent thrombosis, other causes, what you mentioned, could have take little more time, though even if it is happening a little faster also, there'll be chest discomfort, some sort of arrhythmias, VPCs, things like that, and ECG changes. Then going to hypotension. It's not that suddenly happening. So presentation always invariably tells you that it's some sort of tamponade which has happened. We did have, all of us have who do primary PCS have such experiences. And as you have highlighted already, it is mandatory to do an echocardiogram. Even if it is taking 5-10 minutes time, in primary PCS, it is like that. Otherwise, sometimes whether reperfusions are precipitated, or I feel we give little more heparin, makes a keep ACTs little on the higher side during the procedure, that itself could dislodge little clot which has formed and led to such things. We also did face one such, but immediately we could tap. Other sometimes we did detect it before, and CT or MR could help in preventing the further worsening of contained rupture. As you said, planned procedure without heparin and taking the patient for surgery, we could save 1 or 2 patients like that. All of us have such experiences. But again, your case highlights the fact that echo should be mandatorily done. And any thin layer of effusion, again, we should be extra careful, because any acute MI with a layer of effusion, you have to always search carefully whether there could be some sort of contained leak like that. I think that thing is highlighted already. Dr. Prabhakar, sir?
Sir, beautiful case. Very, very good case for people to learn a lot of things to learn. See, when you do an ACS and go for an echocardiogram before the procedure, generally look at 2 things. One is the mechanical complication and the pericardial effusion, which Dr. Srinivas clearly beautifully highlighted. And second thing is look at AR. Because when you have an aortic regurgitation, you always never try to miss a dissection of aorta also. Because that is one thing where you can burn your fingers very badly by giving heparin and everything with an ascending aortic dissection. And I've seen patients who have had antiplatelets and surgery delayed, and patients collapsing and dying because of that, because of rupture. In your case, one thing is the echo technician, you say, had probably missed the whole thing. Now, your patient has been hemodynamically stable for so long, and a probably small rent with a thrombus that was there and not much of pericardial effusion. See, you've only given heparin. You've not given any thrombolytic agent. Just with heparin, giving for about, let's say about 1 hour of the procedure. If you have done it, whether it can dislodge the thrombus and produce an acute pericardial tamponade is a little questionable. Second point is, how did you manage the pericardial effusion that happened? Did you do an auto transfusion? How did you manage the pericardial effusion once you made a diagnosis? Did you take the patient to the cath lab at all? And did you do a check shot? Any other causes?
Yeah, so this is what we were discussing in the lab. The patient collapsed. We came, we asked the sister, she said, the heart rate went down. We looked at the monitor, the associate looked at the monitor. It was a 2:1, and then it was a complete asystole. And we started to do massage. We did a echo at the bedside. We large effusion. We tapped it at the bedside. There was no time to shift him to the lab actually, and did an auto transfusion also. One of the things which could have also happened is sometimes you have an improvement in the LV contractility also. And once the LV contractility improves and the heparin dissolves, the heparin dislodges the clot, maybe the presentation can be acute. He was already on low molecular weight heparin for 1 to 2 days as a part of the medical management. And then on top of it, we gave heparin. Although I'm very, very cautious of giving heparin and monitoring the ACT, especially in elderly patients. And now we err more on this side of keeping it slightly on the lower side now that we have better antiplatelets. Our usage of GP2B3 inhibitors is almost negligible. But this case was around 7-8 years back. So he was on aspirin, clopidogrel, and unfractionated heparin as we do in the procedure. The ACT was well maintained. So no otherwise issue of groin or other things. So possibly I think it's a combination of things that happened. Part of reperfusion injury, part of LV contractility improvement, part of dislodgement of the clot, whatever it happened. But it was so catastrophic that we didn't have time to take him to the lab and do a check shot.
But not check. I agree with you there. That in an emergency, it's not possible. The echocardiographic images that you showed me, the echo where you had a short axis and a parasternal long axis before showing the apical four-chamber, which you went in retrospectively. Can you play that again? The echo images?
Yes, sir. Yes, sir.
The cine loop that you had recorded. Don't go to the retrospective, go to the previous one where during the problem you had a pericardial effusion. You showed those images. Do you have any dynamic images there? Cine images here? I think you played some cine. Okay, now go to the next one, please. Now see, there is here, you have tapped the pericardial effusion.
So this is the point you see, that's a clot over there.
Yes, so you have tapped the pericardial effusion. Once you've removed the tamponade, these patients actually show a good LV function. Is this a similar LV function that you had at that time? See, the entire posterior wall is not contracting here at all.
No, this is actually after the patient arrested. I think some sort of documentation. That's how the movement is not proper.
2:1 AV block, is that the cause? No, because generally when you tap a pericardial effusion, whatever I have seen, the LV function changes. LV function changes, and you get to know if the tamponade is relieved, then you know what the LV function is actually doing.
But before patients arrest directly, sir, if you do it early, you get that.
You can
already patient arrested.
And your original, like the next one, next slide, please.
This is post-arrest, post-CPR, everything going on together. It was a very sort of a thing. And
now I'm just trying to figure out if they can find out any other cause. Nothing more. Go to the next one, please. Yeah, this is the original one. Is this? Okay.
This is the one which is prior to the procedure. This is the one which was done in the main echo lab. So this is what you see here. There is something over here which is bothersome. Retrospectively, there's some effusion over there. Sometimes it can be passed off as a pericardial fat also. But if you look
only anterior, I don't think you give much of importance because there's no posterior pericardial effusion, and it is I don't think it's contained.
So see here, this.
Now I agree with that part there. What you showed as a rent is very possible, very much possible.
This is the LAD territory, isn't it?
Yes, sir.
I mean, the patient had a circumflex-related infarct.
He had a circumflex-related infarct, but he had a critical stenosis in the proximal LAD and also a critical stenosis long segment in the circumflex, both. Look at the right panel. See, look at the right panel along with the color. You look at that 11 o'clock position of the LV. You see that area. It's clearly having a sort of a discontinuity, and there is something which is beyond that, which is probably an effusion. It's clear from this retrospectively that he definitely had a contained rupture, and it goes.
I totally agree with you on that point. There is something happening there. But for that kind of a rent, which seems to be actually looking like a valve in this particular image that you're showing, it looks more like some kind of a valve-like mechanism which seems to be holding it there. But there is not much of an effusion. So is it some kind of a I don't know. You can't do an echo now, so it's not possible. There should have been some kind of an aneurysmal portion there.
No, basically, it's a contained ruptures are like that.
Contained rupture.
Some small clot, it will be once you give heparin, it gets dissolved.
The idea here to present is that this is something which can easily be missed by an echocardiographer routinely, even if he knows about the clinical dynamics. It is possible to be missed by an experienced interventionist also. It is possible to be missed by a primary interventionist also. Unless you are actually...
I agree with your diagnosis. I think I'm just retrospectively trying to avoid a mistake, learn from others' mistakes, which is what I'm trying to do.
Yeah, so we presented this at Europe also. And in fact, I learned from there, one of the operators who said that we do an MDCT in such cases wherever we have a small effusion. And MDCT is something which picks these things up. And it actually, as I mentioned in my presentation also, it makes a difference. The radiographer also has to be astute, and your clinical suspicion and judgment has to be very, very astute, because this is something you really have to think about before you actually can, manage it. And once these kind of catastrophes happen, it's very difficult to save these patients in most of the centers, although yes, they can definitely be salvaged, but it becomes very, very difficult.
Actually, I had one case pretty similar. I mean, it was a primary angioplasty, about 1 to 1.5 hour window period. And the first picture showed a sort of a thrombotic occlusion of the OM1, which was a big vessel. And in the second picture, the artery leaked into the pericardium. I mean, all our contrast which we injected, probably the vessel had a clot which was sort of allowing flow through normal lumen, but the clot got dissolved with heparin and other treatment that we give. And the first picture did not show a leak, but the second picture, by the time we took second picture, it was leaking from the distality of the vessel. And thus a clot which was probably preventing a leak got dissolved with whatever heparin we gave for angiogram. And that's how the patient leaked. We could see between picture 1 and picture 2 a big difference. So we were lucky that we could see it. Everybody was alert. And we could seal the leak and carry on.
We'll go to the next presentation, Omkar.
Sir, Dr. Amit Thopte sir has already joined. So,
thank you, sir. Thank you.
Thank you. Thank you very much. Dr. Amit?
Yeah.
Can we share your presentation? Can you share your presentation? Any challenges, sir? Yeah, it's loading.
Good evening, everyone.
Yeah.
I'm presenting today an unusual case of stent thrombosis. I'm Dr. Amit Thopte. I'm working as an interventional cardiologist in Anand Vishwesh Hospital. So history goes like this. 42-year alcoholic patient with no comorbidities, no history of diabetes or hypertension, presented with angina after heavy exercise. ECG showed inferior wall MI. We did the 2D echo, which showed LVF of 45% with hypokinetic inferior wall. So patient was counseled about the coronary angiography, and patient was taken for angiography. And this was the shoot. The right coronary shoot showed thrombotic total occlusion in the mid segment of the RCA. The left system shoot were normal, having plaques around 40 to 50%. So after passing the wire, the RCA recanalized. This is run through wire. We pre-dilated with 2.5 by 12 mm balloon. The mid lesion was tight. The proximal to mid segment, the mid to distal segment was stented with 2.75 by 40 mm drug-eluting stent.
What pressure do you go generally?
Around 12 atmospheres. And in overlapping fashion, the proximal to mid segment stent was stented. This was 3 by 28 millimeter. This was the shoot after stenting proximal and mid segment. Post dilated with 3 by 8 mm NC balloon. This was the last shoot, which was taken out from the outside to see whether the ostium is covered or what.
You used any
Patient
GP
was
blocker? Did you use
discharged on day 3. He was on aspirin plus clopidogrel. On the day of discharge in the evening, we got a call that patient presented in the emergency with severe chest pain. ECG demonstrated inferior ST segment elevation. He subsequently had cardiac arrest while shifting to the ICU, but luckily revived after 15 minutes of CPR. Then we immediately rushed to the cath lab, started machines, and technician came. We shifted the patient to the cath lab, and this was the first shoot.
Did you do an echo before taking this picture?
No, sir. Actually, when we got the rhythm, we immediately shifted the patient to the cath lab. So with difficulty, I could manage to cross the stents with filter FC wire with the loop. After wiring also, there was no flow. We took 3 mm NC balloon and did the daughtering.
You're thinking of clot in the stent?
Yes, sir. It was an instant thrombus. After some daughtering, the flow was established in the RCA. Meanwhile, we have given intracoronary tirofiban around 10 ml, which is 500 microgram.
You know, in acute setting, I always give intracoronary tirofiban. It's a small dose, but I think it works very well. Doesn't produce any issues like pericardial effusion and so on. So bolus and probably another bolus towards end of the procedure. This I do pretty routinely. I don't know what is Dr. Prabhakar and Dr. Srinivas' opinion on intracoronary tirofiban. A very good salvage. The right is very big vessel.
Yes, sir. So this time we changed clopidogrel to ticagrelor and the patient was stable after 4 days of operative. So stent thrombosis is of two types, early and late. If it occurs within 30 days, we say it is a early, and late is beyond the 30 days. Most commonly, it is a early stent thrombosis which occurs, accounting to almost 70% of the instant thrombosis. And the risk factors which are responsible, the clinical ones are young age, alcoholics, smokers, diabetic patients, then renal failure, then non-compliance to the drugs, which is most important factor here. And also in primary angioplasties, sometimes we can get such a cases of early stent thrombosis. Angiographic features where we can get this is the small size of the vessels, or in this case, as we deployed long stents and multiple stents, these are the angiographic risk factors, and procedural risk factors are the under expanded stent, then malposition and dissections. Although we did not go with the coronary imaging, OCT and IVUS, but angiographically, there was no dissection, and the expansion of the stents were good.
Have you stopped using clopidogrel for acute MI? I think that I would learn this from this case, that clopidogrel has a definite evidence of resistance, and that is in quite a sizable percentage. So I would probably use Trachegrel always, or maybe even Prasugrel. But I think I would probably take this as a take-home message from your case.
Yes, sir.
Dr. Topte, what do you think is the cause here? What has happened in your patient?
Sir, retrospectively, we asked him. So he had a fever episodes 5 days back, and which was not he not told it during the angioplasty. Otherwise, I would have postponed the angioplasty for next 7 days, because we know time and again we have seen in patients with infections, especially this COVID infection, the cytokine storms occur in first week of the infection, and it is such a hypercoagulable state. Your routine antiplatelets don't work, and patient was in a hurry to go to home, and that is why we usually give heparin, low molecular weight heparin for at least 3 days. But this patient was in hurry and discharged on day 3.
No. The issue is,
can you show the
first time
angiogram
when
of
you
the
did
initial
this case,
presentation? The first presentation of the angiogram, the initial MI, the RC angiogram, please, once again.
No, you did not use any GP blockers during the first time when you did the case, isn't it?
No, sir.
I think we should all make it a habit, because we all give one of the oral antiplatelet agents, but giving it intracoronary on table during cath lab is our routine funda. So you just give one bolus after you put a wire down and some flow has established. So the intracoronary injection will also go to the distality of the vessel and probably dissolve clot in the microcirculation. So we give one bolus right in the beginning, once the wire has gone through, and one towards the end of the procedure after stenting is done, and so on. So I think GP blocker is probably a strong necessity in an acute MI setting.
Dr. Topte, a couple of points. One is
next scene. Can you show? Just finish this once. Sorry, can you show the next film once the wire is done?
Once the wire.
We
Flow
need
has
to
come,
see
no?
where the proximal stent was placed actually. Did it come to the ostium?
No, once the flow, next to flow, once the flow, because
Next angio. Next shot. Yeah.
What is your suspicion, Dr. Srinivas?
No. What I was thinking was generally, if you undersize the stent, then probably there's more chance of stent under expansion, maloposition, thrombosis. The artery looks very ectatic, and bigger size vessel we have used 2.75 and 3, which will be less size for this bigger artery. Artery looks like 3.54. After post expansion, after second time you expanded, the artery looked quite big. Immediately post procedure, the artery, the mid segment looked big, the proximal lesion site looked less. So that's why probably you didn't do imaging, but it was not expanded very well. That could be the cause rather than all other inflammation, other things, which is also a possibility. But second time also you didn't you put on ticagrelor, but prasugrel is the indication for stent thrombosis. Once you have that, then as sir said, if you are more worried about thrombus, you can always use GP2P3 receptor blockers. But especially in this sort of thrombotic lesions, at least we should give ticagrelor, prasugrel. If not, clopidogrel is not a right choice. I think we have learned that now. And in the times of COVID, though, we are seeing more of thrombosis, and we are always careful to give little more low molecular heparin follow-up also. And I feel primarily it is because of little thrombotic lesion as well as stents sizing also, and expansion could also be a matter.
The long agree on this stent sizing. For an acute case, AMI case or a primary angioplasty, I always oversize and underdeploy. I mean,
yes.
You take half size more because the vessel is constricted.
Yes.
And when you put a matching diameter, it is probably undersized. And then it's not a good idea to stretch it with high pressure, because there are lots of clots which get broken up, fragmented, and go distally and probably block the microcirculation.
Slow flow.
So I would also agree with Dr. Srinivas that slightly under low pressure, a bigger diameter stent.
Your second stent was at the ostium of the RCA, Amit?
Yes, sir. Yes.
So I think if you look at the if you look at the angiogram in retrospect, the diagnostic, just play the diagnostic angiogram once more, please. I mean, this is a usual thing which happens is that whenever we are dealing with an acute MI situation, the plaques which are non-critical actually become more critical. Your guiding induces some sort of a spasm. So you look at the initial angiogram, I think in retrospect, you had enough space to deploy the stent beyond the ostium, maybe just proximal to the proximal lesion, maybe the proximal part of the ectatic segment, and avoid the ostium actually. Because if you look at your next picture, when your guiding is there, that ostium now starts to become more significant. And this happens with all of us. This really happens with all of us. And what I have realized in my limited practice is that once you're able to establish a flow into the artery, just relax, take a deep breath, maybe have a cup of coffee or something, which is too exaggerating, and re-evaluate the coronary, because spasm, thrombus, guiding induced spasm, and try to minimize the length of your stent, use vasodilators, because you have two long drug-eluting stents implanted in a right coronary artery in an inferior wall MI, and this patient has come with a stent thrombosis. Luckily, he was salvaged, but I believe these patients actually need to be stented with less of metal, more of vasodilators, more of waiting, but at times may not be possible. The situation may be so critical, you are the alone operator, your technician may not be available, and you just want to put in a stent and come out. Second point about oversizing, yes, with OCT and imaging, we have realized that these arteries are much bigger than they actually seem during the acute intervention, and possibly oversizing the stent and at a low pressure, at a moderate pressure, and then not doing a post-dilatation is also important. Third, yes, either ticagrelor or prasugrel, no clopidogrel in such a scenario. And fourth, I think we have experience now with IV cangrelor also. And I think with the usage of IV cangrelor, we are very, very comfortable in such high-risk situations wherein the thrombus also disappears, the bleeding is not an issue like the GP2B3 inhibitors. And maybe you get more time to assess the vessels, maybe use a microcatheter, deliver the nicorandil, nitroprusside, adenosine, whatever, and make the artery big and stent as less as possible. So these are some of my thoughts.
But stent as less as possible, but try and use a bigger diameter stent.
Yes, sir. Yes, sir.
A couple of points with these patients. One of these things is, I think 2 stents, what he has done, the strategy-wise, what he had planned originally is good. Sir, Sirish Ramat sir point about using a 2B3A upfront is excellent, because by the time we give loading and the loading starts acting, it takes about 30 to 40 minutes. And if your balloon time is much shorter, the 2B3A is a gap in which the stent thrombosis can happen, the stent can create problems. So it is very, very useful. I usually use that, sir. The second thing that I use during an acute MI is, the moment there is an antegrade flow, I also give an intracoronary nicorandil. That prevents the slow flow that keeps happening after you dilate it. So that also is very useful thing that happens in these patients. Regarding stent thrombosis in this patient, I think any primary PCI, ACS, TEMI setting, I think it is time to stop coming out of clopidogrel and straight away going in for either prasugrel or ticagrelor. Prasugrel seems to be the least amount of stent thrombosis. And that is, the resistance to prasugrel is much less than ticagrelor even. And in fact, we had a study from Ramchitra Medical College here in Chennai, and their data showed clearly that prasugrel is the best in terms of avoiding a resistance to the drug.
Wait, Dr. Srinivas, what is your feeling? Do you use prasugrel or you use ticagrelor?
No, out of the potency of antiplatelet efficacy, prasugrel is the top, ticagrelor is in between, clopidogrel least. But why ticagrelor is preferred many other places is, it is a very balanced thing. It doesn't have too much of bleeding. Prasugrel sometimes in elderly patients, and when you're using along with GP2B3 receptor blockers, post-TK type of scenarios, there's a worry of little more bleeding. That's where ticagrelor scores. And that's how ticagrelor is becoming very popular, because balance between the efficacy and problems of less bleeding. But agreed, prasugrel is more potent. You see this in this angiogram I was telling initially, the mid segment of RCA looks bigger than the proximal lesion site. This always should make us worry that even without IVUS or OCT, we should make us think that that place has not expanded. We should have dilated with a bigger sized balloon there. Okay, we all learn from mistakes. As I already told, ostium is again, unless it is absolutely essential, try to avoid involving ostium, because ostial has a different circular fibers. The chance of restenosis could be higher. If it's diseased, where you have to definitely involve, there is no choice for you. But here they had a good stump. Always check with the baseline picture, because later on, once you handled it, the ostium went into spasm and all that. And probably if you have to use a small stent there in the first lesion, and then probably lower stent could have avoided that coming onto the ostium and all those problems. But definitely if you see that original lesion site, the proximal lesion looks much lesser sized compared to the mid segment of RCA. These are just learning points. If you are not having imaging also, you have indirect evidence that this artery could have not, stent could have not expanded there. So I think nowadays, most of the people end up using very long stents, especially in acute scenarios. But that is a scenario where we need to optimally size it and do appropriate sizing and avoid too much over taking too much longer stents. But if there's a thrombus, you can take 2 mm more to just oppose the thrombus. Otherwise, edge protrusion of stent, thrombus comes, you are always worried about it. That is okay, but try and avoid taking too much large stents. And as Sir said, appropriately size it. Don't go to too much high pressures for slow flow. Those are the learning points. And all of us, I think, now are switching to ticagrelor. As Sir was asking, what is our protocol? We use ticagrelor and aspirin in acute all patients now before shifting. And if the patient is young diabetic, where you're more worried of bleeding, those are some subset of patients where you might prefer prasugrel. But by and large, ER protocol is we give ticagrelor as well as aspirin along with statin. And regarding GP2P3 receptor blockers, as a policy, we straight away are not using it. But after doing a procedure, if that sort of appearance persists, any residual thrombus-like thing or if slow flows chances are there, then we always tend to use GP2P3 receptor. This is one area where we still continue to use GP3-beta receptor blockers. Unlike most of the elective patients, the usage is very less with more potent antiplatelet drugs. But as Sir said, in acute scenarios, we can use it. And new addition, as the doctor mentioned, was did you use cangrelor, sir?
Situation and the length of the stent, I think it's a very long length. Probably 2 stents together was probably more than 60 millimeters.
Yes.
So I think that is also very important in making a decision that the clopidogrel action has not kicked in.
Yes.   Yes.   Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes.
When you are finishing the procedure.
Other thing people are following as Dr. Samir mentioned, I think, cangrelor in the acute stage. And then by the time the effect goes, at least 1 hour is there. So the other ticagrelor starts acting. That's how the other people are saying. But when you are able to, when you are anyway taking an hour's time to shift from the ER, then people argue out, by then the effect comes. But if you are shifting it too fast in smaller centers, where shifting time is just 5 minutes, 10 minutes, patient is on table, then those are the scenarios where you should be you could take help of cangrelor also, as it is available and little cheaper. But by and large, this sort of sizing of the stents is what we have to learn from this, apart from the ticagrelor usage. Never proximal artery can be smaller in diameter compared to mid and distal artery. That means stent has to be underexpanded there. That's the point we have to learn, just to emphasize for everybody, I'm saying. Thank you.
I would feel, Dr. Srinivas, we generally don't try to stretch the stent too much.
That's why you said, no, sir, you'll take bigger diameter stent.
Yes. So bigger diameter at a slightly lesser pressure is probably more appropriate for AMI situation where clot is expected.
Sir, we have good experience of using IV cangrelor, especially in very sick patients now. The patients who come with cardiac arrest, patients who have severe vomitings, patients who are in cardiogenic shock. We have used this drug very, very effectively. And the biggest advantage is it starts its action within 1 to 2 minutes. And by the time your procedure is over, you stop the drug, the effect goes away very fast. So very fast onset, very fast offset, no issue of problem in hepatic dysfunction or renal dysfunction. And the time the patient is most sick, especially the ones who are on ventilator, who are in shock, this drug has actually salvaged. And then we can obviously switch over to ticagrelor. You can give in between also, but prasugrel and clopidogrel, if you have to use, you have to give only after cangrelor infusion has stopped. So, I mean, that is something which we need to know. And we have used at times in intra-procedure also, when you have had some sort of intra-procedural stent thrombosis or maybe some haziness. The idea is GP2B3 inhibitors actually have a long half-life and they take long for the effect to go, and bleeding complications maybe more when compared to cangrelor. So we have experience now about 20-25 patients, especially in sick situations. We don't use it right, left, and center, but especially the sick patients who are on morphine, who are vomiting, in whom absorption is an issue, who are in cardiogenic shock and all those kind of opiates. So these patients have done well.
Actually, we did 100 cases where we used cangrelor before it got approval. And we had great results in all 100 cases, no stent thrombosis at all. So I would probably feel that cangrelor should become a drug for primary angioplasty in most of the cath labs.
You are giving ticagrelor, sir, immediately also after cangrelor?
Yes. I think first thing we give is ticagrelor aspirin. In fact, so many times GP calls from home, patient's home, and we tell them to load with ticagrelor aspirin. So ticagrelor, I feel, is a very, very safe drug to go in, yes.
Even with cangrelor, it can be given.
We had a problem with ticagrelor about several years back when it was launched. In case you had to go for surgery, the surgeons never touched it if you give ticagrelor.
In fact, it's the safest.
Yeah, sir, but they never accepted it. So we had a problem when we had to go for an emergency surgery or following a loading. So the policy originally was, now we are back to ticagrelor loading in the emergency. But the policy then became give clopidogrel, and once you decide on the PCI, load them with ticagrelor. But those are the scenarios where your 2B, 3A starts working. Now, if you load it outside and come in within 40 minutes, the drug starts acting. The ticagrelor is very effective. You may not really require cangrelor in those cases.
In fact, ticagrelor was developed as a bypass surgeon's drug, and in fact, it's safer to operate on ticagrelor than operate on clopidogrel because of it.
Samir, I totally agree with you. But
surgeons don't agree.
I had a big problem trying to convince the surgeons this is a shorter acting drug.
Yes.
Prasugrel also, they are worried more than ticagrelor actually. Prasugrel, they said more bleeding.
But I would agree on that front, because prasugrel A has a long duration of action. Like even if you stop prasugrel the action will continue. On that contrast, trachegalor is twice a daily dose. So if patient has received trachegalor in the morning, and if you're taking the patient for surgery later in the afternoon or evening, I think it's a reasonable gap.
In fact, if you look at guidelines also of stopping the antiplatelets prior to a surgery, for pasugal it is 7 to 9 days, for the clopidogrel it is 5 to 7 days, and for ticagrelor it is 4 to 5 days. So ideally on ticagrelor
5 and 3.
Yeah. So we have an experience of using cangrelor without clopidogrel, aspirin and cangrelor in a young 38-year-old guy who actually came to us in shock and had a bad triple vessel disease. We could not do anything angioplasty wise, put him on IABP and asked our surgeon to operate. And he was on aspirin and cangrelor. And so he was operated within next 6 hours because cangrelor was stopped and he survived. So that is another advantage of cangrelor, is that very fast offset. So luckily, this patient directly came to us instead of being loaded with clopidogrel at other hospitals. So that is another advantage of cangrelor.
The wisdom when you use cangrelor is moment you stop, the action goes off.
Yes, sir.
Absolutely, sir.
So you must have antiplatelet action going on in some way or the other by the time you stop and switch to something else.
We had this one patient in whom we used cangrelor during the PCI, and post-procedure the patient had hemoptysis, and we stopped the cangrelor and the effect went off and the patient was intubated, but he survived. But we have lost patients with hemoptysis and things like that on GP2B3 inhibitors in the past, especially with epciximab and eptifibatide. So I think probably using this drug more judiciously of its fast offset and doesn't have any issues, even if patient has renal failure or hepatic failure. And in some cases, you can even use intracoronary cangrelor in the same bolus dose of 30 microgram per kg, like we use intracoronary GP2B3 inhibitors, with the additional advantage of not causing bleeding, or even if bleeding has happened, the reversal is faster without any antidote.
I think that last part of your sentence is very, very true and very useful. That moment you go off, the action is off. None of these other things, like even the weakest of them, the conventional unfractionated heparin, probably would increase the bleeding component if something goes wrong during the procedure. So cangrelor, probably I would feel off action is more important than the on action.
That's why I tell sir, no surgery in acute MI. No surgery in ACS in acute MI, because it is not easy for you just tell surgeon to operate unless there is a mechanical complication. No surgery in acute MI, because now latest guidelines also say that the clinical presentation of the patient is most important, by which we have to decide the management aspect, not only the anatomy. So even if it is left main, Dr. Hidamat sir put stent. So that's how it is. Acute MI, electively, if you want to do it later, it's a different scenario. But doing a surgery in acute MI, especially in centers which are not geared up, is not easy. Your surgeon also will hate you if you ask him to operate in your acute MI scenarios. So that's why I say no surgery in acute MI. And by the time they arrange everything, precious 2-3 hours is lost. So patient myocardium gets damaged, even if you have to do it early. So that way also it's a problem, and the side effects like this bleeding, all this is also a problem. So unless you have very strong reason, like a mechanical complication, something, we avoid sending patients of acute MIs for surgeries.
There was another study where they took the patient for primary angioplasty, but the lesions were too ugly to get a stent. So all that they did is put a wire, did some balloon dilatation, put some GP blocker, established the flow, stabilized the patient, and went for surgery next morning. Anyway, surgeons like a cushy time, so they work well during the morning hours. And I mean, this is not very often, but I think one should definitely consider establishing flow. I think that is what, and keep it going till the patient goes for surgery.
Even the primary CABG that we talk about, it's done only within the first 6 hours. Beyond 6 hours, the mortality is very high.
That's why I'm saying it's not easy to do primary CABG within 6 hours. You need to have a full-fledged geared up setup, and this worry of whether patient was already preloaded with such antipotent antiplatelets and all that is a worry. So if at all you have, you can do a culprit vessel PCI, and then probably surgery can come later if you have so much of disease bother. Nowadays, most of the patients even get multivessel PCI, do all right. If you see Dr. Hiramat sir's patient, what he has presented last time, it looks stents are so great things nowadays. So even the complex of the anatomies could be corrected. The bifurcation thing, what showed the proper planning and doing it right, the patient's outcomes are much better. Unfortunate, some 10-20% patients who reached nose, for which all 100% did not suffer. So that's what I feel, especially in the acute MI, it's not easy to operate. So I made it a protocol as a rule that acute MI, unless there is a mechanical complication, and patient coming within a very short duration of time, it's not easy to send patients. A primary CABG term itself is not very easy to get it done within 3. By the time patient comes, 1-2 hours is gone for us. The time angio is done another hour. It's not easy for the surgeon to mobilize everything within to operate within 6 hours. That's what I always felt. Sir has to show something. Go ahead, sir. I didn't know that you had.
No, I mean, if you want to see something, I have a case. Dr. Omkar, can I show presentation?
No, always pleasure to watch your cases, sir. Please go ahead.
Thank you for that, Srinivas.
Lot of learning, sir. That diagrams which you show, all that youngsters should follow. How to plan the procedure and how to execute it is also important. Just like that ad hoc things, that sometimes plan might change, but initial planning, how it is done and all that, how sir describes is a lot to learn. Please, sir.
Dr. K. Abraham always used to do that. That picture in the lab has to be there before starting an angioplasty.
All right, I have a case. Now this right coronary is it's a 10-year-old inferior wall infarct. This gentleman didn't feel like getting anything done, and even angio was not done. But close to his retirement, he thought he will not get reimbursed once he retires. So he came for evaluation, and this is how the angiogram was. Artery which is occluded, right coronary, and this is a 10-year-old occlusion. And you can see lots of collaterals coming from left system, which kept him going for, say, these 10 years, and he could continue to work. But you can also see significant calcium along the vessel wall, whether it is an intimal calcification or an adventitial calcification. It's many times an issue, but we must respect that there is calcium along the right coronary sort of flow. So this calcium so many times could create problems, especially in a thrombotic situation. Agreed that this is a 10-year-old infarct, but stretching these calcified vessels is a big issue. Use of rotablator and things like that would again be sort of not a happy situation. So here we took a guide which was well sitting, and then this is a guide 2 which failed to cross the lesion. We have a microcatheter, and we are trying to probe the site of occlusion, but the vessel is just going in all different ways. Finally, with Conquest Pro 12, we were able to achieve a good distal position for the wire. The wire position was clearly helped by presence of calcium. You can see all along this wire track, the RCA is outlined by the calcification. However, our problem did not end here. The balloon was not going. So on the wire, none of the balloons, including 0.85 balloon, was not going. So It was a big issue. So we came downsizing from 1.5 to 1.25 to 1.0. These days we have 0.85 balloon also available, and it did not work. So what could be the options? I think many a time we take long sheets because it supports the guide catheter very well. Then balloon touch, the downsizing we did, Nick Nano Hydro is a very good balloon which can go through. And then you can take a support with a micro catheter, which will help you push the balloon forward. So many times we take a support from, like, say, this is a course of the wire, but you can park a wire in some branch, put a balloon there, and with that you can get your guide in deeper. And these two together, they sort of help you take a good support. Then we take Corsair or Taunus. Taunus, I think these days we have stopped using, though there was a phase when we were using Taunus. Anchor balloon, I spoke to you that you park the anchor balloon in one of the side branches, and it will help you, your guide, to come in. A guide liner and guidezilla are pretty common in our cath lab, and the guide catheter, generally we like to take a bigger diameter catheter. I think those centers who are radialists will probably not agree with this, but clearly a bigger diameter catheter has a strong support. And of course, if it is not a thrombotic lesion, but becomes a great help. Now, this is some other case, but you can see a very, very thin-looking vessel and a disease, but the distal part is filling up quite well. So in this case, we have this 0.85 balloon. So this was also not going. And this was held by a guide liner. You can see guide catheter tip is here. Guide liner is advanced on the balloon, and you can see the balloon tip moving forward. So this was a Nick Nano Hydro, and ultimately we were able to achieve a good result and excellent flows on this case. This was another case where again Corsair is used, and you can see 1.5 millimeter balloon, 1.25 was not able to cross, but Corsair crossed easily. And once Corsair crossed, you can take it back and come down with the balloon. So, I mean, people generally try to think what is the difference between Corsair and microcatheter, but Corsair has a lot of support in this area, which will allow a clear forward movement. So once wire is across, I think putting a Corsair down is probably a strong support. Then this is what I was telling you earlier. A wire and balloon are placed in the side branch. This is the side branch. And then you work through the CTO. You can see the wire making good progress with the support. The guide is actually strongly supported with the side branch balloon. And this is how we are able to cross with the wire. And this is the final result. So in our today's discussion case, we're able to cross the total occlusion, which was presumably 10 years old, with a Conquest Pro 12 wire. And the wire across the balloon not going. This is the situation we had. The corsair tip can help you cross the CTO. Like in this case, the wire had crossed, but the corsair balloon is not crossing. But you can get the corsair further down and then take it back, and then you can bring in a balloon. And thus the corsair has a strong support from behind. So back to our case. So in this particular case, we put a rotawire through the microcatheter, and we did a rota to right. This was actually initial balloon was rota burr was 1.25. This was some other case. Patient was asymptomatic and has a positive stress test. There was a lot of discussion on this LAD lesion. You can see in this view, the LAD lesion looks important. In this view, epicranial, the LAD lesion doesn't look very important. However, we do FFR, and in FFR, we could get an FFR with adenosine, which was less than 0.75, and thus this particular vessel got a stent. We double-checked with IVUS, and you could see a round calcification. So it needed something else before we could get a stent here. So rota was done, and then you can get a nice result with a stent. So artery, which was looking like this, question mark critical lesion. However, FFR was positive, so important to do. And when we moved from physiology of FFR to IVUS, you could see a dense 360 degrees calcium. So this was addressed with a rota and then a stent. So this was another such case where patient had an angioplasty attempt in a peripheral center. However, the operator felt that the lesion is not giving way. He was with a Sprinter 3x10 and waste persisted. This was the image sent to us by him. And then we used an OPN NC, which can take very high pressures. And you can see there is no waste. So you could use a cutting balloon, you could use a rota, you can keep a parallel wire on the side, which acts like a cutting balloon, and then take a non-compliant balloon. But you can see this OPN NC this was at reasonably low pressure, but it's 2-layer, and you can use pressures like 25 and 30 with OPN NC balloon. So it's trying to discuss what are the ways in which we can address. This is a typical rota. Rota is very good for calcium, which is along the intima. But if you have deeper calcium, the shockwave balloon is the current option. Now here we have Guidezilla. Going deeper, you can see guide catheter tip is somewhere here. Guidezilla is slowly advanced forward, as you can see here. It is supported by a balloon, and we are able to take good support from Guidezilla. Once balloon dilatations were done along the length of the right coronary artery, through the Guidezilla, which was advanced to bring in a long stent. See, the stent comes in very easily through the Guidezilla, and another stent is placed on the backside. Then the subsequent part was using a high pressure NC balloon and dilated the whole length. I find this GuideZilla or GuideLiner, for that matter, very useful to carry the long stains and so on to the distality as well as through partly opened up lesions. And so this is how we ended. The right coronary had 2 long stains, but it is very gratifying. Though this guy has lived 10 years without anything done to the total occlusion, you can see a very big right coronary artery is opened up, and I'm sure it will keep him alive for many more years, happier years than with an occluded right. So I will stop here to take some questions or comments from anyone.
Thank you, sir, for showing interesting cases. And then the first case also highlighted how the retrograde filling helps when you inject from both vessels. You see how it's coming up almost there, and the calcification also is highlighted, but the segment was not that too long. That was a little positive thing, though calcification was a negative thing. So retrograde always take injection help of the opposite contralateral injections in identifying CTO. And you,
I think in CTO, very often we take bilateral injection. In fact, so many times we inject at the same time. And that really outlines some vessels which are connecting left to right or right to left. And that's delineate a course very, very well.
Yes, I think that aspect was shown very well. And rotablation, another newer addition, now it came for more proximal and ostial lesions, probably is also orbital atherectomy, where I think there's some advantage where you can burr back while coming back from distal to proximally also, with less worry of stuck burr. And it doesn't demand so much of operator experience like the traditional rotablation, which Shar showed. IVL is again useful value addition, but only thing is expensive and more for deeper calciums. And LAD, what Sir showed, that LAD lesion proximally, it looks less in one view, more in other view. That suggests that probably the lesions are oval shaped, which you clearly see in the IVUS again, which Sir showed. And haziness in one view again suggests not only thrombus, but a calcification also gives that appearance. And with imaging now, we become more wiser that why it looks like that in one view, other. The oval shape, if you look from one side, it looks tight, other side, it looks less. And the more the proximal lesion, more longer the lesion, the more likely to come positive in FFR. That's how the LAD lesions came positive, and the patients got stented then it did well. Those are some of the interesting points which I thought I would further emphasize with what Shar showed. And obviously, always a pleasure to watch what Shar shows cases. I think any other comments from my Prabhakar sir and the others? Otherwise, we'll close.
Sir, it's an amazing array of cases, like all kinds of ways in which you can tackle a difficult scenario wherein you can't cross. I have only one question on the anchoring balloon. What size balloon do you use? You used a 1:1, and what pressure do you go when you anchor these balloons? I've never done one.
You use 1:1. The idea is to get a good grip. If you use a small diameter and low pressure, worried about a possibility of dissection, it will not give a strong grip. So it is 1:1, but low pressure, something like 6 or 4, and slip your guide catheter on that. But these days, I think with GuideZilla and GuideLiner, I think the necessity for this kind of technique is not there.
Yeah, I don't know. Somehow I had used GuideMate too, like we had discussed in one of our previous meetings, and found that that was more useful, and it moves with the tip is so soft that it goes in without the milking effect of the GuideZilla or the GuideLiner. So that was something that I had felt. So I had never actually used. Since you showed a case, I thought I'll learn in case it comes in handy when there is a GuideZilla that is probably not available or some issue with that might come in handy. So 1:1, and you inflate it only when you want it. Otherwise, you keep it deflated. Am I correct, sir?
Yes. I mean, the whole idea is to get the guide deeper in.
That's it.
So once you are in good position, flight pressures are good, I think you can deflate it. And Dr. Omkar, I think we should think of stopping today's meeting.
Yeah, so I think, sir, it's we can stop. We had a very interesting case discussion after a long time, after a month's time, in fact. So last meeting we conducted on a last month 20th. So same day. So we will be catching in the next month on a third Thursday with 2 more interesting cases and a lot of discussion. Till then we will stop, and I wish a good time ahead. Thank you very much.
Thank you.
Thank you.
I think all of us must keep thinking about the cases that were presented. Maybe you're driving, but you can still think of the cases which were presented today, and see how you can do them differently, and maybe have some comments in the following meetings.
Thank you.
Thank you, sir.
Okay.
Thank you. Thank you very much.
Thank you
Good
very
night,
much.
sir. Good night. Have a nice time.
Right, sir.
Thank you, Srinivas sir. Thank you very much, sir.
Thank you.
Thank
you.
you, everyone.
Thank you.